Hello, everyone. My name is Emmanuel Nwatu, and with me is Shelby Bouchard and Iman Musani. We are here to present an important topic called the use of coercive psychiatric practices in Black communities, an initial overview. This study is part of a project which focuses on the coercive psychiatric practices on Black and Indigenous people in Ontario and Quebec. And this study, the project tries to look at how Black and Indigenous people in Ontario and Quebec are disproportionately affected in the psychiatric system. It might interest you to know that from what we've learned for the past few days, that Black folks have less tendency to access mental health care. But if you look at the psychiatric system in Canada, Ontario, Canada, in the US, and in the UK, you'll see that Black population are overrepresented. And why is this the case? Despite existential barriers, despite the racial injustice happening, despite the lack of culturally competent mental health care, but yet still they are still overrepresented. So now it's important for we to understand what is coercive psychiatric practices. Coercive psychiatric practices are those treatments or interventions that in the mental health system that imposes on individuals with their free and informed, without their free and informed consent, with force, pressure, such as or manipulation, such as seclusion, restraint, forced treatment. So, and for the purpose of this study, we are going to look at involuntary admission specifically. An involuntary admission is a type of coercive psychiatric practices through which individuals in the psychiatric system are hospitalized and treated in a psychiatric ward without their consent. And we are going to look at the studies conducted in the US, in the UK, and in Ontario, Canada, because in Canada, the healthcare system varies from province to province. So we are going to look at the legal framework in the for involuntary admission in UK, USA, and Ontario, Canada. The step one is admission processes. Who are those that admit or could apply for admission for involuntary admission? First is either in the UK is the family or professional. In the USA, it is the family, professional, or police or judge. Then in Canada, is either the police, the professional, or a judge. Then the second is assessment. On assessment is either the approved mental health professionals in the UK or a doctor. Then in the USA, a psychiatrist or a psychiatrist, psychologist, or social worker are those who can access for involuntary admission. Then in Ontario, Canada, is an attending physician. Then step three is the decision to involuntarily admit. What is the time lapse? Then in UK, up to 72 hours for emergency. Then if it is for assessment, it is for 28 days. Then after assessment, and they feel like, oh yeah, this person is mentally unstable, if they feel that there is need, then it is 6 months for treatment, which is subject to renewal. Then in the USA, it is up to 72 hours. Then after 72 hours, then it is subject to court orders that could give a particular time frame or time lapse for it. Then in Ontario, Canada, it's for 2 weeks, subject to renewal. Then the last part is the criteria for involuntary admission. In the UK, a person can be voluntarily admitted when the person has severity of mental health or need for hospital detention. Second is the risk to self or other people. Then the third is the refusal or inability to consent to admission. Then in the USA, it is the danger to self or danger to others or grave disability. In Ontario, Canada, it is the risk to self or other violent behavior. Also, lack of competence to care for themselves. Then third is the mental disorder is likely to result to serious bodily harm to the person or another person, or serious physical impairment to the person. From this now, we could see that despite the nuances, the outcome is still the same. So my colleagues will talk on the type of review, future direction, and what this entails.
Hello, everyone. My name is Shelby. So moving to the beginning of our scoping review, we had the task of starting to take a systematic approach to the data that we're collecting. So we began with a broad database search, which rendered just over almost 3,900 results from a range of sources. After the duplicates were identified and removed, that left us with 2,652 studies to sift through. From there, we began to focus in on coercive psychiatric practices, specifically for racialized populations. So studies that were outside of that and deemed irrelevant, that rendered us 194 studies, which we then moved to a full text review. And that excluded 136 studies. So at this point, we're moving from coercive psychiatric practices as a whole and racialized populations as a whole to working with involuntary admission, specifically with Black populations across the populations that we studied. So at the end, that rendered us 58 studies. And as you can see, there's a large difference in the amount of studies and where they're coming from. So over 2/3 of studies are from the UK, who has been collecting racial data for decades now. 2/3 the USA, there's 13 studies. In Canada, there was 5. Within Canada, 4 of those were from Ontario and 1 from Quebec. We couldn't find any outside of that. And as Iman will tell you, there's specific reasons for that and part of our mandate for this. One of them was also mixed population, so it was representing the UK and the US. Now, what became clear very quickly, but also as we continued to approach things systematically and continue to move forward, was that Black people are disproportionately subject to involuntary psychiatric admission, and this was across the populations that we studied. Evidence also indicates Black people in these countries have significantly different pathways to psychiatric care, and there are disparities in the nature of the treatments along those pathways. So, for example, psychotherapy, it was shown that it tends to be much less available to Black people as a course of treatment. And finally, Black people are also, like from our results, Black people are a lot less likely to seek help in times of crisis and are much more likely to be taken to the hospital involuntarily by police. So we're seeing multiple levels of coercion through different parts of the psychiatric system and through the pathways to care. Yeah, so it's very, very striking. And yeah.
Okay, so now looking at what this means and where we're going to go from here. So evidently, there's a clear racial component in the use of involuntary admission for psychiatric care. And this is even after researchers control for other sociodemographic variables. So things like income, things like education, that some people try to argue are the real issue. Like people who don't want to talk about race often say, oh, it's just because they're poor. But when we control for all of these things, there's still like a very clear racial difference, which is quite concerning. And it points to the urgent need for culturally safe mental health services for Black communities. And that starts in hospitals where involuntary admission is happening, but it also is, the two presentations we just listened to, talking about what does it mean to provide culturally safe support for people. It's not just telling clinicians to get a cultural competency training. It's really like integrating things that are salient to communities that are meant to be served, which is clearly not happening at this point. And then the other thing we notice, of course, is that there's a very distinct lack of Canadian research in this area. That's because we do not systematically collect race-based data, like in hospitals, through like census data. Police forces don't collect it. We are moving a little bit further in that direction. The RCMP has a mandate to collect race-based data. Of course, all these institutions on their own have their own agendas, and so we don't know what will come from that data. And individual hospitals are also moving towards collecting data, but really what this points out is that we have a lack of systematic collection, which is problematic. And so in terms of our next steps here, we will be continuing the review of literature for other racialized populations, specifically Indigenous populations in Canada and the US, and also looking at other types of coercion like forced medication, seclusion, restraint, and then also other types of coercion that are maybe less obvious, such as like financial coercion to make people seek treatment by withholding income or essential resources like food. So looking at these things can help us to better understand what the unique parts of experiences are for specific communities, including Black and Indigenous communities that we know are the most marginalized racially in Canada specifically. And then, of course, this review adds to already large, but also still growing base of research that is suggesting that we really need to be collecting more race-based data. And I think that's the biggest takeaway of all of this is that we, as we heard in the last presentation, the experience of Black communities in Canada is unique. And even within that, there's so many different experiences, and we don't know what those experiences are on a large scale because the data is not being collected. And so that is a huge push. And researchers are doing it on their own, but I think to move this forward in the urgency that it requires, it does need to be done more systematically. And then, of course, there are legal and policy implications. So one of the questions, the biggest question really that this type of review raises is what is the use of police and policing in mental health care, and why are we using so much police and policing, both, by police and also, other types of policing like monitoring, surveillance in hospitals and stuff like that. Thinking about those things, and then once we identify what the nature of the harms, we know that there are harms, but the nature of them, we're able to kind of address them better. And then in terms of policy, of course, hospital level regulation is obviously important since involuntary admission is only one of the types of seclusion or one of the types of coercive practices that are used towards Black people and other marginalized groups. So that's kind of where we are. This is the first stage of a very large project. And so we would love to hear feedback, and also there's more to come. Thank you.
Thank you so much. Do we have any questions for our presenters?
Great presentation. I just had a quick question. So you mentioned in Canada that we have a lack of race-based data, and I guess we're working towards collecting more of that data. And you also mentioned something about like other institutions collecting their own data and things like that. I just wanted to ask, do you think that there could be any negative implications of that data collection? Like, could it be used to actually oppress Black people or other racialized groups even more when it comes to, involuntary admission and other, practices that are used? So that's just what I was wondering.
Yeah, that's a great question. And the answer is yes, which is why when I mentioned that the RCMP has a mandate to collect race-based data, that is quite concerning in my opinion, just because there are certain institutions, most of our institutions are historically and currently marginalizing Black communities, as well as Indigenous and other marginalized groups. And so I think it becomes it's really important to have the data so that we can use it for purposes like this to understand what the harms are, what the unique experiences are. And also there's a risk in those early stages and even beyond that it'll be used by people who have a certain narrative in mind, and they'll use the data to push that. For example, people perceive Black communities or Black patients coming to hospital to be more violent. And so, if you have the data, you might be able or willing to take from it things that support that notion of violence when in fact that's not there. So I think it has to be coupled with other things, the data on its own can't speak, but it's research like this that's trying to understand things in a way that can contextualize the data.
Also, to add to what my colleague stated, one thing with data is that it can be used for good, and also it can be used for something negative. So, but the thing is that if we want to really see that there is marginalization of Black people or any other marginalized group, we have to really use data to access this. So, and also some recommendations in the Ontario Healthcare Plan. They also talked about a systematized race-based data. It's part of their recommendations to the Ontario Healthcare Services generally, because if you look at it, you see that there is no adequate race-based data that reflects on, okay, Black people are marginalized, because sometimes they could say that, okay, yeah, this is not, I don't think is a problem of race. They could actually try to, put it in as something else that is not race. But race-based data will show evidence or facts that, okay, yeah, there's really marginalization of this certain group. But the question you asked is very important, because obviously this can also be used as a weapon for, infliction of harm on a certain race. So I could agree to that.
And you have time for one more question.
Maybe not a question, but a comment, because I think what you said is very important. And as you guys were presenting, you may have seen I'm looking and thinking so much about what you're sharing. It's important because with the data, and I'm going to say with our data, because this is the data about our own health, our own wellness, that can be used for our good and against us as well. But making the link with what was shared earlier with our social worker, Danielle Samuels, nothing about us without us is a principle that Indigenous communities have already been using very well. And I think that within the Black community, we need to advocate for being at those decision-making tables and at all of the echelons where information is going to be used. So that's healthcare workers, that's policymakers, that's researchers, that's everyone that's going to be touching that data, having a role with how that data is interpreted, used, and communicated. Even things like individuals who are doing social media or journalism, they have a role with how this information is communicated to our community, communicated to us, and to people who care about us as well. So I think it's important to always have that on the forefront of our mind, but also to use that knowledge that that data is important, but who is sharing and communicating about that data is important too. We need to take all our place so that we can protect for ourselves and advocate for ourselves too. Absolutely. Thank you.
Thank you, everyone. That's the end of our concurrent session. It's now time for lunch, so you can head up to the 4th floor at FSS 4007 to eat.